Good evening, everybody. We're glad you could be here for the Fall Transplant Symposium. I'm sorry we can't be here in person, but hopefully you'll get a good sense of sort of what's been happening with the program and get a sense of sort of where we're headed and get a lot of questions answers, particularly surrounding COVID. We're pleased to have Aruna Subramanian join us today, and I'm sure we're going to get lots of questions about sort of what the current guidelines are and what it means for patients who have had transplants. The state of the program, and as Helen put in the program, the state of the program is busy. We've had our busiest year in a really long time. This past calendar year, we had our busiest single calendar year transplant ever. And so that made us the fourth largest transplant program in the country, behind Cedars and Duke and Vanderbilt. And so when you look at our academic year, we also had a similarly big year. If you look at our fiscal year, which goes from September to December, we did 97 transplants. So we almost broke the 100 mark for that particular year. So if you look back at the past 3 years in the United States, we've done 217 heart transplants, which makes us the biggest volume transplant center in the Bay Area by far. We're over 3.5 times our next biggest competitor's size and volume, and that's CPMC. And we've had great outcomes, fortunately. Our 1-year survival from our most recent look at our data is 93.2%. And when you look at the US overall and look at everybody who's transplanted in the US with a heart transplant, the survival is 91.5%. So we've had excellent outcomes. We've gotten a lot of people transplanted, and we've gotten a lot of people transplanted very quickly too, and faster than most centers. So it's a real accomplishment, but I think the real accomplishment is the people who make up the program. And there's been some changes and some new faces and some old faces changing places. So I thought I'd go over that. So new faces, as our transplant program has grown, our clinics has grown. I'm sure you guys have seen more and more people in the waiting areas if you're able to come to clinic in person. We've increased now to 5 post-transplant coordinators, 4 of which are relatively new. Many of you may have met them already. So Jennifer, Lori, Karen, and Stephanie have all joined in the past less than a year. And so Rebecca is still here as our sort of oldest, longest serving coordinator. A couple other familiar faces, maybe to some of you who've been transplanted recently, is Whitney. Whitney joined our inpatient APP group that helps us take care of our VAD and transplant patients. That group is also expanding in number to a total of 5. And you didn't see Gabby on the last slide because Gabby has transitioned out of her role as our post-transplant coordinator, and we were sad to see her go, but we were super happy that she decided to stay around in Stanford, and we were able to coax her to joining our inpatient APP team on the transplant and VAD team. So you'll be seeing more of her on the inpatient side rather than the outpatient side. Some other new additions and transitions. So Hannah has joined our VAD program. She's a new VAD coordinator. And the reason why we had a space for a new VAD coordinator is because Nicole, who formerly had that spot, also decided to change positions, but fortunately, again, also within our program. So Nicole has moved over to take on the role of a pre-transplant coordinator. So Hannah has filled her spot as a VAD coordinator. With all this change, it means a few people that have been with us for a while have also said goodbye. Many of you have known Kathy Town for many, many years. She finally retired this past year. We definitely miss her energy and enthusiasm in clinic. Alex Lapin has been one of the inpatient APPs on our transplant and VAD team since just after I got here. And Alex could have moved on. He also stayed within Stanford for another role, kind of moving up the ladder in the world of the advanced care providers. And lastly, Pam, who many of you may have known very well from your time before you got your transplant. She was in charge of sort of shepherding people through the process to get transplant. She is also retired, and her spot is the spot that Nicole has taken. Speaking of some new faces, our fellows started this past July, and many of you may have met them in clinic already. So Layla, Dan, and Stephanie will be joining us for the next year. They're a great crew, and so look for them in clinic and make sure you say hi. On the physician side, we have a couple of, I guess, somewhat new additions, but they're people who have been around for a while. So Petra was one of our fellows from last year, and fortunately we got her to stick around and stay on as an attending. So now you will see her in the transplant clinics and VAD clinics as well as on the inpatient side. And Hannah, after a long stay at the NIH, has come back to Stanford, and we're happy to see her back. And you will see her in the outpatient transplant clinic starting in the next month or two. And lastly, although we've added some physicians, I'm sad to say that Shirin Jimenez will be leaving us as of December. Shirin is moving to Sacramento to be closer to her family. She served as the associate program director for the past couple of years. I, for certain, will definitely be sad to see her going, as will the rest of our partners. She's done a really fantastic job kind of behind the scenes and organizing clinics and organizing some of our quality programs and quality metrics. And we're sad to see her go, but we're happy that she can be closer to her family. So lots of comings and goings with the growing program, but hopefully we can continue to grow. And as things change, we'll let you know. I appreciate everybody's patience with clinic as things have gotten a little bit busier. Hopefully the wait times haven't gotten too long, and we'll try to get you through as fast as we possibly can. But please feel free to feed back to us if there's things that don't seem to be working, or if there's things that you think that we can do to make your experience in clinic better. So with that, I think I'll turn it over to Michael. So Michael has received his transplant back in 2013, and he's been sort of a real go-getter in terms of volunteering for the program. He's been a real valuable member of our sort of transplant community. He served on the PFAC for about 4 years. He's worked with Donor Network West. He's been part of our peer-to-peer program as well. And when you don't find Michael volunteering, you can find him biking and kayaking and doing all sorts of outdoor activities. He also has a white lab his name doesn't happen to be Gabby, it is Gabby, and it's named after Gabby Oro, one of our former post-transplant coordinator, who's now one of our inpatient folks. So you can see there's quite an attachment between our patients and our faculty and staff here at Stanford. So with that, I'll turn it over to Michael to give you his welcome from the PFAC.
Good evening and welcome to the second annual virtual symposium presented to you by the Stanford Heart Transplant Patient, Family, and Advisory Council, or PFAC for short. Our council is made up of 8 patients, 3 caregivers, our Stanford faculty advisor, Dr. Jimenez, our nurse practitioner, Gabby Oro, and our lead faculty advisor and one of the original founders of this PFAC, research nurse manager, Helen Lucard. Now, 2021 turned out to be another challenging year with many highs and lows. In January, we started on a high note as we began to administer the vaccine. I believe we were all hopeful that this vaccine would be the answer to our prayers and get us back to a normal life. Unfortunately, this vaccine came with a number of issues. How do you literally vaccinate an entire world? Who gets it first? Is this vaccine still effective with all these variants? What about people that don't want to get vaccinated? Are masks effective? And finally, is this vaccine effective with the immune compromised folks? And what about this booster? It seems like this vaccine came with more questions than answers. And to make it even more confusing, everyone from our media to our politicians to even our next door neighbor became an expert on COVID. That is why tonight we are going to devote much of our time in answering these type of questions with some of Stanford's best experts. Now, even though these can be challenging times that can lead to a lot of confusion, anxiety, and more questions, you have to remember who we are. We are survivors. Once you receive a heart transplant, you become part of a very special family. Now, the entry fee, it's a little on the high side, but nevertheless, you become part of a family where your brothers and sisters really care about you. That is one of the reasons why our founders created this PFAC, a council that was devoted to helping other heart transplant recipients and caregivers. For instance, we help to champion the monthly group counseling sessions put on by our awesome social workers every month. We developed a peer-to-peer program where we have trained volunteers who are either heart transplant recipients or caregivers that are trained to help you. So if you're going through a difficult time or just need somebody to talk to, reach out to your social worker and take advantage of one of these programs. Because remember, this PFAC is here for you. Finally, if you would like us to address certain topics or certain questions, either in your newsletter or our next symposium, email us, and you can find our contact information in any of the newsletters. And by the way, don't forget to read our newsletters. They're very good. We put them out twice a year, and they are filled with articles from our doctors to our nurses to our social workers and from many of you, all covering a wide array of topics that are pertinent to you. In closing, I would like to give a big thank you to all the members of this PFACT, especially our chair, Susan Robertson, and our lead faculty advisor, Helen Lukart, who put in an enormous amount of time to make this possible. I would also like to thank all of our speakers tonight, and especially all of you for tuning in. Finally, at the end of this symposium, don't jump off. I'm going to come back on and introduce to you 3 breakout sessions that we have to offer. You have the opportunity to choose one of the 3. They will last between 20 and 30 minutes. So, to no further ado, let's get this show on the road. Dr. Teuteberg, please take it away.
Thanks, Michael. We really appreciate it. And we really appreciate all the efforts of the PFAC to make things like this and the newsletters and all the other efforts that you guys put together to really build us as a community and inform the patients as to what's been happening, not only with the program, but into other things that impact them like COVID and what's happening with precautions that we need to take in clinic and in the hospital. So thanks to you, and particularly thanks to Helen for organizing all this. It's a real sort of tour de force every year of her putting this together. And I think the challenges of COVID certainly haven't slowed her down in getting us on our toes and keeping us together and allowing us to at least to interact virtually once a year. So with that, I'm going to turn it over to Eldrin Lewis. You met Eldrin last year. So Eldrin is the chief of cardiovascular medicine, and even better, he's part of the heart failure group. I've known Eldrin for a very long time. He was a junior faculty at Brigham and Women's when I was doing my fellowship there, and I was pleased that he came here as our division chief. He's brought a real energy to the program, and we're very excited to sort of see the changes ahead. He has a real passion for clinical research, and I think we're going to see our clinical research program and infrastructure really explode over the course of the next couple of years. Eldrin's research in the past has focused a lot on heart failure, and heart failure specifically looking at quality of life, how it impacts heart failure and how our therapies impact quality of life with heart failure. And I think that sort of that passion for quality of life really not only is part of Eldrin's research, but as part of sort of his ethos clinically. You can really see him and his efforts devoted into not only having patients survive longer, but survive longer with excellent quality of life. And so I'll turn it over to Eldrin for a brief hello.
Thank you so much, Jeff. I really appreciate it. And I have to say, on behalf of the entire Division of Cardiovascular Medicine here at Stanford, I just want to say welcome. It's really an honor to be here, not only as the chief of cardiovascular medicine, but as a card-carrying heart failure and transplant cardiologist. I've been doing this for a long time, and just seeing so many faces, seeing so many people here really warms my heart. Last year, when I was asked to participate, I was excited, and I don't think I had met a single person. But now I'm starting to meet people in transplant clinic, and I'm getting charged to see how well everyone's doing. Just for those of you who don't know me, a little bit about my journey. I actually grew up in Mississippi, and I saw firsthand kind of the ravages of kind of the impact of social determinants of health, comorbid conditions leading to heart disease and kind of, unfortunately, early death. Many people in my home state of Mississippi never knew about heart transplant as an option. And I would venture to say that there are some people on this call that probably wouldn't have known if it weren't for access. When I look at our program, I'm very proud. And I'm proud because I look around and I see all of the different aspects that we offer, and we can actually provide care to patients from all walks of life. When you look at such a high volume and then you have a 94% survival rate, that is impressive. That is much better than you would see across the country, and it's a reflection of the teamwork. All of the people that you've heard about, that you've seen, it is incredibly important to get this number. But this is not just the teamwork from all of the staff and the doctors and the pharmacists and everyone else who's playing a role, the social workers, but it's also you. It's your home team. It's what you as individual patients are doing, because we often will ask you to do a lot of things, especially in the beginning. And sometimes you may understand it and sometimes you don't, but it's all to try to help you get to the finish line. But it's also your support team. We don't transplant patients, we transplant families. And without the family, it's hard to get through. Some of you could have an easy road and some will have a hard road. Some after the initial, getting over the initial transplant becomes smooth sailing. And for others, it may be a little bit of like being on the Colorado River in the Whitewater Rapids. But regardless, your family is there at home. And then also your Stanford family is here with you. So we're excited that you're doing so well. We're excited that you're here. And someone wrote in the chat a little earlier that you're a survivor, and I agree. I would say the Gloria Gaynor song applies here. I will survive. And you'll survive by everything that you're doing, by reaching out when you need help, by being a part of PFAC and continuing to continue to strive and to thrive. And our goal, our mission, certainly with my interest in quality of life, our goal is to take the patient out of you and replace it with the person, so that you don't have to start thinking of yourself as just a heart transplant patient or just a patient who has high blood pressure or diabetes or kidney disease or any of these other things, but a person who has dreams, has hobbies, wants to spend time with their families and their grandkids and their kids and travel, to crochet, to do all of these things that make you whole. So I would say continue striving. I'm excited to hear all of these different lectures. And once again, welcome and thank you, Heather. Thank you, Helen. Thank you, Jeff. Thanks, everyone.
Thanks, Eldrin. Really appreciate it. I mean, we'll get into kind of the meat of the program now. I have the pleasure of introducing Aruna Subramanian. I'm not sure where to start with Aruna, so she was the perfect person, I think, to talk about what we're going to talk about this evening. She was the founder and the co-director of the Transplant and Oncology Infectious Disease Program at Hopkins until 2013, when she came to Stanford. She now acts as the director of the Immunocompromised Host Infectious Disease Service, which basically is the group of infectious disease specialists that help us manage our transplant patients, particularly our heart transplant patients. And her expertise, among others, is on respiratory viral infections and immunocompromised hosts. So again, who better to talk to us about COVID-19? Aruna's been sort of in the thick of it in terms of research around COVID-19. She served as the site PI for the remdesivir trial here at Stanford. She's working with Regeneron and their monoclonal antibodies for treatment of COVID, and also a co-PI for the Janssen vaccine study that's ongoing. She's also part of the IRIS study, which we'll probably talk a little bit about in terms of the long-term follow-up of patients who have recovered from COVID-19. So it's my pleasure to introduce Aruna, who would talk about treatments, vaccines, boosters, and impacts on heart transplant recipients. Aruna, thanks for joining us.
Great, thank you. Thanks so much, Jeff and Eldrin. And thanks for inviting me to be here. Let me share my screen. So today I'm going to talk to you about COVID-19 vaccines and monoclonal antibodies, but I'm happy to answer questions as they come up as well, and really want to focus on how these things affect our heart transplant recipients and how you can use these to your advantage to really live safely, and hopefully can answer some of your questions and have it be less confusing. It's not going down. I don't know why it's not moving forward. Okay, there we go. So early in 2020, we knew that our outcomes were poor in transplant patients, but poor overall, really, because we were sort of blindsided by COVID-19 and really overwhelmed in many areas of the country in terms of ICU admissions and how to take care of patients. So the earliest study of a registry of transplant recipients had 482 patients, and of them, 78% had been hospitalized. Close to 40% required ICU treatment, and nearly 30% were on the ventilator. Their overall 28-day mortality was high at 19%. And the risk factors for severe disease at that time were pretty well known: age over 65 and comorbidities like heart failure, chronic lung disease, obesity. But thankfully, through the year, we did see decreasing mortality. From when they looked on this registry, the mortality from March to near the end of June was 19.6%. But when they looked at patients who were diagnosed later in June to December of 2020, the mortality had decreased to 13.7%. And that was a testament to our improvements in treatment regimens and learning really how to take care of patients with COVID-19. But still, this wasn't good enough. Of course, there was a need for protection, and we were waiting for the vaccines. Thankfully, the 2-dose vaccination series did reduce infection and death in transplant recipients. You know, we hear this, that vaccines, you know, are they effective in transplant patients? People are really worried. And I will talk about the overall efficacy, but the good news was that overall we did see a reduction in disease and death when we gave patients 2 doses of vaccine. So in a UK registry study of 48,000 people who got 2 doses of vaccine had mortality rates, they died at rates of 7.7%, compared to the unvaccinated who were dying at a rate of 12.6%. So you could reduce death even if people got 2 doses of vaccine. And then among patients at UCSD, 2,000 patients they studied, they said they saw the incidence of COVID-19 go down by 81%. So their incidence risk ratio was 0.19. That means they reduced the incidence of COVID-19 by 81% in their vaccinated transplant recipients. So there is some positive news with the vaccines in transplant patients. But what were the antibody responses after 2 doses of the vaccine in solid organ transplant recipients? And one of the first studies was from Hopkins, looking at 658 participants. And you can see the lines going from dose 1, and the yellow dots are what the antibody levels that people had after their 2nd dose. So after 1 dose, about 15% developed antibodies against COVID-19. And after 2 doses, 54% developed antibodies against COVID-19. But that meant that still 46% were antibody negative despite the 2 doses. And there were many studies like this that showed a suboptimal response to 2-dose vaccines in transplant recipients. And some of the studies looked at only antibodies, which is one arm of the immune system, and some looked at T-cell responses, which is the other arm of the immune system. And lung transplant recipients had the lowest response to vaccines, but heart and lung transplant both had lower responses than liver and kidney recipients. So that's when the idea was to study something more. What were the risk factors to not responding to vaccines? So if you'll see the lines that are completely to the right of the hashed line, those are the folks that had a higher risk to not respond to vaccine. So people who are older age, people who were on triple immunosuppression, or if they were on high corticosteroids, or mycophenolate mofetil. So these are common things in transplant patients, and these are risk factors for not responding. And even pre-Delta, we were seeing a higher risk of breakthrough infections compared to the general population. You can see that the numbers were still low. This was a survey of 17 transplant centers, and there were 151 breakthroughs seen. of 18,000 vaccinated patients. That's still only 0.83%, so low numbers, but unfortunately of those, 87 were hospitalized and 14 did die. So two of these studies did document household transmission from unvaccinated family members. And so that's why one of our concentrations, one of our efforts is to really vaccinate family members, caregivers. It's so important because, you know, our family, as Dr. Lewis said, is really what provides us support. And we really need to make sure that they're all protected as well, so they cannot give us COVID-19. And that's when the consideration for a third dose of vaccine came up. The first paper on this was from Israel of 96 heart transplant patients. And before the third dose, about 23% had IgG in their study, that's antibody. And 18 days after the third dose, it increased to 67%. And this was using the Pfizer vaccine. So this was very reassuring. Then from Toronto, they did a randomized placebo-controlled trial of using Moderna as a third dose. And in both arms, you'll see that even in the placebo arm, there was a positive response. So even months after your second dose of vaccine, you can still be producing more antibody. So the placebo arm did improve by 17.5%, but after they got their third dose of Moderna, the amount of antibody went up 55%. And even neutralizing antibody, the more protective antibodies went up dramatically in the third dose arm. And they looked at the other arm of the immune system, the T cell response, that also improved after the third dose. And they found very few adverse events. People didn't really have much in the way of side effects. The usual side effects we're seeing, but nothing worrisome, and no rejection episodes, very importantly, at both 4 weeks and 3 months follow-up with stable graft function. So that was a very important study, and it was placebo-controlled. So what are our overall vaccine recommendations? All transplant recipients who got Pfizer and Moderna should get a third dose. Now you'll see that the FDA is going to recommend either one. It doesn't really matter. You can mix and match now. And it can be 28 days after the second dose. There's some confusion. Do I have to wait 6 months after the second dose? No, that's the general population. But immunocompromised folks, transplant recipients, can get their third dose 28 days or more after their second dose. So this is really not a booster. This is a third dose. It should be part of your primary series. And please go ahead and get it if you haven't. If you're in the small minority that got J&J, then now it's been approved that you can get a second dose, either with J&J, but I would say it's preferable to get a second dose with Pfizer or Moderna, because then there's a study showing that you have a much higher boost of your antibody levels. If there's no response to 3 doses, there's little chance that a 4th dose will help, unfortunately. Though there is one small study of unpublished data that if you have some response to the 3rd dose, then a 4th dose may help. So, you know, we can talk about it if people are interested, but really the overall message is that if there's no response to 3 doses, unlikely a 4th dose will help. And then better to get vaccinated pre-transplant, of course, if possible. Family members and caregivers must get vaccinated. And don't change your immunosuppressant medicine doses. This hasn't really been studied, even though we've talked about risk factors, unless you're directed by your transplant team. Then I'd like to quickly get into monoclonal antibody treatments, because this is, you know, people ask, well, if I didn't respond to vaccine, what can I do? And this is what really we should be doing for our transplant patients who develop disease. There's an emergency use authorization for treatment, and these monoclonal antibodies prevent severe disease and hospitalization. all transplant patients with mild infection are eligible if they're outpatients and within 10 days of symptoms, as long as they're not on oxygen. You do an online survey, it's a red cap form, and you'll see the link there. But if you Google Stanford monoclonal antibodies, it's the first thing that comes up. And it's an IV infusion. Right now it's being done in the Hoover building, the Hoover Pavilion, next to the Neurosciences building. So that's if you actually develop mild infection. And the earlier you can get this done, the better. If you've been exposed, had a serious exposure to somebody with COVID-19, then even before you have developed symptoms or get a positive test, you too can get an infusion of a monoclonal antibody. It's the same online screening form, and patients themselves can fill out the screening form and sign up for it. Of course, please do let your transplant team know. So this is where monoclonal antibodies really play a big role. We are using it as what's called compassionate use for transplant patients in the hospital. It's a lot of paperwork. We apply to the FDA and Regeneron to use it off label. And it's thought to be likely helpful only if you haven't developed antibodies and you're sick enough to be in the hospital. And what we are going to be starting pretty soon is a study of pre-exposure prophylaxis. So that's people who aren't even exposed to COVID-19, transplant patients who have not developed any antibodies to the vaccine. We're going to be checking that as part of the study. And we'll be infusing monthly treatments. It is going to be placebo controlled. So you have a 75% chance of getting the antibody versus a 25% chance of getting placebo. And we'll be giving monthly treatments and hopefully really reducing any risk of developing COVID-19 in transplant patients. So these considerations are monoclonal antibodies should be used early. And if if you're exposed, you can use that as well. And masks, we could talk also, I can answer questions, but really transplant patients still need to be careful and avoid crowds with unvaxxed people. There was a question as to what mask is the best. Of course, your special HEPA filtered mask or the N95 or KN95 are really the best masks, but they're hard to wear for long periods of time. The next best is a surgical mask, but it should be well fitted. Some people wear 2 layers, and 2 layers can be helpful. And cloth masks are really not recommended for transplant patients. They're too porous and don't really protect you well enough. So, and there are some outpatient antivirals coming soon. There's a new oral antiviral called molnupiravir, which hopefully should be available soon. It will be easier to use for people who can't get access to monoclonals, but I would still recommend monoclonal antibodies for our heart transplant patients. And remdesivir IV has been used has been studied outpatient too for 3 days, people coming in for 3 days or people who are in rehab or in a nursing facility can get that for 3 days, and it really does help prevent hospitalization. So that's what I had for an overview, really concentrating on vaccinations and monoclonals.
Great, Aruna. Thank you so much. That's a great review of a very complex subject. There's a lot of questions coming through. Maybe I'll try and kind of condense them. I think probably the most common question that I see here in the chat, but we get a lot in clinic, is if the studies are using antibodies to assess response to 2 doses or 3 doses, is it something that you should have done clinically? Should you have your antibodies drawn?
No.
And if you do, what does that mean?
That's a great question, and we do get asked that a lot. There was a recent webinar on this as well, and the thought is, we don't know exactly what the correlates of protection are. We're assuming that a certain level means you're protected, but the recommendation is actually not to follow this routinely, because you don't really know, you shouldn't just assume that, okay, I have a high level and I'm protected and I can, take risky behavior, or, that if you're really low, should you live in a bubble completely? No, you probably have some protection through T cells and other mechanisms. So it's so hard to know what to do with these. It's really only recommended to use it in a study environment, and we will be using it in the study of pre-exposure prophylaxis.
Great, thanks. I mean, I think that it's one of the other sort of questions that has come through is that you mentioned the third dose being separated by 6 months if you're not a transplant patient, but it can be as early as 28 days if you are a transplant patient. Is there like a best time to get it if you're a transplant patient, or should you be looking to do it as close to 28 days as you can?
I would say, yeah, many of our transplant patients would be almost 6 months by now if they got it early. So definitely get it now, but the sort of minimum is 28 days. So if if you got it later for whatever reason, then all you have to do is wait a month and get the third dose. As I said, I would do it as though it's part of the series if you're a transplant patient, not consider it a booster.
And because it's the fall and the time we typically talk to people about flu shots, is there, should you be separating the flu shot from your third shot, or if you're going to start your series, if you haven't had them already, is there a specific time, or can you get them both at the same time?
You can now get them both at the same time. Early on, we were saying you had to wait. The CDC had recommended 2 to 4 weeks waiting between vaccines, but the recommendation is now there's no need to wait between vaccines. So you can get them at the same time. It may be you take it and make sure you can rest for a few days, because the combination may really fatigue you, but at least there's no recommendation to wait.
Great. And just maybe two other quick questions. One, you mentioned that you can mix and match a little bit the vaccines, Pfizer, Moderna. Should you try to match if possible, or does it not really matter all that much?
It doesn't matter. The one thing I would say is, if you got J&J, then definitely don't. I mean, then I would say if transplant patients should get Pfizer, Moderna afterwards, I wouldn't rely on J&J because we know the responses aren't as good.
Okay.
We were involved in the studies, but for Pfizer, Moderna, it doesn't really matter. If you had good response or not too many side effects before, then you might as well take the same one. But if whatever's available is fine.
Great. Maybe now there's lots of questions coming through, and I hate to end the discussion, but maybe I'll just grab one. So if the question is, if you had COVID and this person has COVID in the specific setting of getting the monoclonal antibodies, how long should you get the third dose? And if you do, how long afterwards should you wait?
Oh, that's a good question. In fact, that was one of our things we were going to study, right? I think the recommendation is still to wait 90 days after the monoclonal antibody, because there's some theoretical issue of whether you would develop a good immune response, but it really doesn't seem to be bearing out clinically, but the CDC is still recommending that 90 days after a monoclonal to wait for vaccination, which I'm not very convinced with that science, but it is what it is.
Well, great. Thank you so much. That was a really, really great overview of a pretty complex topic. And I think you managed to kind of capture as you kind of went through the slides, I had questions in the back of my mind that I got frequently asked in clinics, and you kind of one by one kind of ticked them all off. So thank you so much for such a complete presentation in such a short period of time.
Sure.
I'll look over the rest of the chat for the remainder of the talk here. And if other questions come up, like I said, maybe we can put them together and send them out as an announcement or a series of questions and answers after the meeting tonight. So thanks again, Aruna. I really appreciate it.
Sure, no problem. Happy to be here.
So next we're going to move on to Tom Pugh. So Tom was transplanted just about a year ago in November of 2020. He and his wife, Susan, both live in Modesto, and he works as a research scientist at E&J Gallo Winery. He has 2 adult children, Brianna and Tyler, and a daughter-in-law, Amy, and a grandson, Calvin. Tom, like Michael before him, maintains a very active lifestyle: yoga, hiking, camping, cycling. And he's going to give us a little bit of a talk about his recent transplant from the perspective of someone who cycles. So Tom, I'll turn it over to you.
Thank you, Jeff. Let's see. I think I should be up. It's not on the presentation mode. There we go.
You can see it.
Can you see it?
Yes.
Oh, good, good. I'm sorry, so my name is Tom Pugh. As Jeff said, I'm a heart transplant recipient and part of the World's Luckiest Person Club. It's been 11 months post-surgery, and I'd like to tell you a little bit more about myself. So here's the outline for the presentation. I'll give a little bit of an introduction, then in a nutshell, I'll tell you my story, and as well as some key takeaways. And then I will also provide thanks and appreciation to everybody who has been involved in saving my life. So I was born way back in 1958 in May. I'm from a small town in Indiana called Mishawaka. People think it's from Wisconsin, but it's really right there in Indiana. It's a stone's throw away from South Bend, which is right close to Notre Dame. Something of interest is I went to high school with my wife, Susan, but we did not date until after college. But because of that, we had a very nice family life living in the Mishawaka area when I was in graduate school at Notre Dame. So I am a microbiologist. I have a BS in micro from Indiana University. I got my PhD in microbiology after working 2 years at Eli Lilly. And I studied yeast molecular biology. And then I did a postdoctoral fellowship for 3 years at the University of Michigan studying yeast cell biology. So I became a yeast guy. And with yeast guys, you do one of two things. You either go off into industry or you go into academia. And I went into industry. I worked for 9 years at Anheuser-Busch, being their yeast person. I worked at Miller for 3 years in Wisconsin. And then I was headhunted out to California to work at the E&J Gallo Winery as the yeast person out there. So, and I am a cyclist. My wife and I took up bicycling about 11 or 12 years ago when we became empty nesters and we needed to do something together. If you do bicycle a lot, you rarely see a married couple that actually cycle together. So this is a picture from 2017. Susan and I rode around Lake Tahoe. So it's about a 75-mile trip. We're also wearing our Gallo bicycling gear. We were captains of Team Gallo for the Best Buddies charity that raises millions of dollars for charitable purposes. So an interesting thing about my story is that it was right in the middle of COVID. So around March 22nd, I had 2 heart attacks. One was the first one, I didn't even know I had a heart attack. The second one, I thought I had the flu. I didn't realize that I was not doing well. My wife took me to the emergency room. That was about the time that COVID restrictions were introduced. The local hospital took a look at me and knew that doctor there took Susan by the arm and basically said, Tom's in a very dire situation, which is not something you want to hear from the doctor. So luckily they had an ECMO device there, the extracorporeal membrane oxygenation device, to help my lungs work as well as my heart. It was the only one present in our county, so we were very lucky. They also didn't have the ability to do anything to help me, so they had to transfer me somewhere. And that was where Dr. Wu and his team brought me on to the Stanford Clinic for heart transplants. And as I mentioned, it was right at the time of COVID restrictions, so I had to test negative for COVID on 3 successive days. So I spent the weekend testing out, and I was placed in an ambulance on a Sunday night and then driven to Stanford. When I got to Stanford, they also saw that I was in a really bad situation. I basically blew out my left ventricle. So Stanford then put me on a tandem heart. I then developed a lung infection. And so I became sick. I was removed from the active transplant list at that time. Dr. Heisinger and Dr. Teuteberg and company and Dr. Wu decided that my best chance at living was to use the LVAD as a bridge to a transplant. So in mid-April, I had the LVAD surgery. I don't remember any of this because I was pretty sedated during that time. I then had a fairly long recovery period. I celebrated my birthday on May 21st. That was when I first became relatively conscious. And also because of the COVID situation, my wife was not able to be near me. So we had lots of FaceTime with the nurses, et cetera, trying to communicate my lead time. So I was in the hospital for about 65 days. I lost 40 pounds. I went in weighing 195. I woke up weighing about 155. And I was released right around Memorial Day. So as I was released, I had to do something that I've never had to do before, and that was having to live with an LVAD. So I have a picture with me in a much better shape, but it's the only time I had a picture of Omar O'Day. He's the gentleman in the top right-hand photograph with the gown on. Omar was our friend. He became a personal friend, family, as everybody's saying, but I had to deal with batteries, controls, wires, alarms. And Omar was there by cell phone, by text, and he was always there. So he was our tether to reality. So I was transferred to St. Francis Hospital on 5/29. The estimated time there was supposed to be about a month. I seemed to be progressing relatively quickly in my rehabilitation, but my time at St. Francis was very different than my time in the ICU, where everybody took care of me. When I got to St. Francis, they made me do lots of work. So because I had to become more normal again, I had to be able to eat and drink. During the time that I was in the ICU, I never had a drink of water. I was given liquids, but I never took water in my mouth. And I hadn't eaten anything, any whole food. So I think my body forgot how to swallow properly. But basically the people at St. Francis, I had to take 4 classes a day, 4 1-hour classes, as it were, each day of the week. That were the foundation of me becoming more fit, and to teach me how to exercise and go through movement, etc. The pictures in the bed there, whereas I had nice, healthy, meaty thighs because of my bicycling, I'm very much the opposite there. So I was very ill, and we had to after we were released from St. Francis, which was only 2 weeks of time, we had to live in Palo Alto for 2 weeks, or no, just for 1 week, rather, for labs and clinic visits. So that whole time was 85 days from home. Here's a couple of pictures of me at St. Francis. St. Francis did something really cool in that they were able to sneak Susan in, even though they were under COVID control. It was about the time when they were going to start loosening up control, but Susan had to stay in my room and stay on the floor. But she's the one who took all these photographs of me walking. I had to walk with a walker. I could only walk 300 feet or so my first time. I had to do stairs. They had a cycling machine, so they actually put me on a bike. I was very excited, but then again, I had to deal with the LVAD around my neck as well. So I got released on Father's Day weekend. This is a picture in the top right of my family. My wife's in front with me. My daughter Brianna is next to my son. My son is with his son, and my daughter-in-law Amy. And I was off the transplant list. So the thing I had to do, and this wasn't written down anywhere, but it was an internal goal. I needed to gain strength in order to improve my fitness for surgery. COVID once again came in and was very difficult to deal with, because there are cardio certification classes that one can take, but everything was closed down. So I had to go to my wife's boot camp. So Susan's boot camp opened. We started walking every day. I walked with a walker for about a month, first a block, then a couple blocks, etc. Come August 1, I was free walking and walking up to 1 to 2 miles. In Modesto, it's very flat, and there's not a whole lot of tall buildings, but we had to find some stairs. So there's a junior college nearby where they had 2 flights of stairs, 25 stairs in each flight. I counted them a lot. But Susan would make me go up and down 10 times, or as many times as I possibly could. And I also had a Peloton that I would use. So these were all very day-by-day improvements. That's a take-home message, because nothing comes fast, especially when you have a long road to cover. In preparing for my transplant, I started back to work on the 16th of September. The COVID came in again. Everybody was working from home and Zooming and having virtual meetings. So I rolled back in. I had a special assignment from my boss, and it was quite easy to work. And then on the 25th of September, I was placed back on the active transplant list. One of the first things I said to my wife when I was in ICU and I had a tracheotomy, the only thing I could say to her as I was conscious was I wrote down a note and said, I want a little dog when I get out of here. And so you can see in this picture is our miniature poodle, Ziggy Stardust. So he always reminds me of me going through this adventure. So I received the call on November 12th. So that was 51 days after the transplant. I arrived at Stanford. I've always been dreaming about what that ride would be like, but we left at 5:30. I was in the operating room at 10 o'clock at night. I don't remember much after 11 or 11:30, but the LVAD removal started at midnight, and then the transplant started at 3 a.m. I have a picture of them lifting me back into the bed, and that picture was dated at 2 p.m. So one thing that's for sure is Friday the 13th is a very lucky day. It's no longer a day of bad luck for people, but I was discharged 11 days later, so a very quick turnaround again. And there are pictures here of me immediately following the surgery or shortly thereafter with all the IVs. And then one of my favorite nurses was taking me on a walk, and this double rainbow was taken. My wife took the picture on the 11/18, but there was a nice double rainbow outside the window. I looked at that as good luck. We had to live in Palo Alto, which again was very odd during COVID. So this is just before Thanksgiving. I was able to, we lived at Homewood Suites in Palo Alto, but because of COVID, I think there were only about 4 other people in the hotel itself. So it was a very quiet, safe environment. We started Susan's boot camp again. We walked a lot in Palo Alto, and when we got home, we started doing the stairs again in the Peloton. And tying this to the fun fact of becoming more normal again and returning to bicycling, I took my first bike ride, a whole 6 miles that took 40 minutes on April 3rd, so of 2021. That was about 4.5 months post-surgery. So during this whole adventure, I was also relatively anemic as well. So coming back from that was difficult. Through the summer, we've been riding quite a bit. We started slow and rode flat in Modesto. And then starting Labor Day, we started riding places where we used to ride before, out in the county in Oakdale, riding faster. Over the past 6 weeks, we only ride once a week. But so in 6 rides, Susan and I rode 145 miles with 4,300 feet of elevation. My longest ride so far was 37 miles with about 1,200 feet of elevation. So I've been getting stronger a little bit each day that I ride, which is the goal I really like, because I feel like I'm a brand new cyclist and I can actually exercise more and get better the next time. But it is a step-by-step and day-by-day philosophy. My key takeaways, the first and foremost is carpe diem, seize the day, enjoy life, do everything you can to enjoy that day. Embrace your second chance at life. Going through the path that I went through made me appreciate everything in my space a lot more. There's always hope. There's always positive hope, and you need to be positive. Start slow and be consistent. You're not going to see drastic changes very fast. But it's important to never give up, to keep going, and to keep moving. And also the hummingbird has a special impact with this heart transplant surgery too, as a touchstone, because of some special things. So I would also like to thank everybody. It's really hard to do that on one slide and in one voice in a 10-minute presentation. But I want to recognize and to be incredibly grateful for the profound grace of the donor's family with their gift of life in the midst of their sorrow and grief in losing their loved one. Also, I have deep appreciation for all the love and care from the amazing staff at Stanford Health Care. I spent a lot of time in ICU and I was moved around. I didn't mention I also had to go in because I had a warfarin bleeding event in October of 2020. But I got to know a lot of people. Unfortunately, they all had masks on. I couldn't really call their names out, but those nurses are truly amazing. I have extreme gratitude to the skilled, extremely talented and caring surgeons and physicians at Stanford. And also the unending love and thankfulness to my family and especially my wife for taking care of me through this extraordinarily difficult time. So with that, my presentation is complete. Thank you.
Well, thank you all. I hope you really enjoyed tonight's symposium.